Hey future nurses, welcome back to Easy Nursing Prep. Yay! Yes guys, we just rebranded to Easy Nursing Prep based on so many reviews I got on how my content is so easy to understand, on how so many nursing students have mentioned they've seen a lot of my questions on their exams, on their NCLEX exam. So we thought to rebrand to the name that really fits the mission of this platform, of this channel. So we are now Easy Nursing Prep. We make passing easy. So Easy Nursing Prep makes passing easy. Okay guys, and if you are new here, I am Nurse Funke. Welcome to today's review. I made a previous video. In this review we are talking about pregnancy complications and labor and delivery emergencies, most tested pregnancy complications and labor and delivery emergencies. So I broke everything down in detail in the previous video. It's good for you to review it before the question and answer section, okay? And please don't forget to support me by subscribing, by liking, by sharing my videos to other nursing students you want to see succeed, to other nursing students you think will benefit from all my videos, okay? So without wasting our time, let's go right into our review. First question. A woman at 32 weeks gestation arrives with persistent vomiting, 6% weight loss, dry mucous membranes, and positive urine ketones. Now, which intervention is the most important first step? A. Start ondansetron PO and discharge with outpatient follow-up. B. Offers more frequent meals and ginger tea only. And C. Begin IV fluids and correct electrolytes. And D. Start insulin sliding scale. Pick your answer, guys. Guys, let's go through it. Let me explain what's happening here before I tell you the right answer. See what's happening here. With the signs and symptoms presented to us, the presentation we have here of our patient. Look, they arrive with persistent vomiting, 6% weight loss, and dry mucous membranes with positive urine ketones. What do you think we have? The patient is going through Hyperemesis gravidarum. This is severe persistent nausea and vomiting during pregnancy that can lead to dehydration, electrolyte imbalance, weight loss. They will lose greater than 5% of their pre-pregnancy weight, right? Also, there'll be ketones in their urine. See, urine ketones, ketonuria. So we have the situation we are dealing with is Hyperemesis gravidarum. They can't keep anything down, throwing up. Okay? And the right answer, just think about it. I want you, when you're answering these questions, you have to be putting your critical thinking. If somebody is vomiting and vomiting, what do you think? They'll be dehydrated. Because they are vomiting, they can't keep anything down. That's why they are losing weight. Because because they can't keep anything down, also their body is now breaking down fat as fuel, and that's why you see the ketones in the urine. There'll be electrolyte imbalance because they are vomiting. And when you are vomiting all the acid out, that will also put the body in a state of metabolic alkalosis. So you have to put your critical thinking in action to understand all this, to put this thing together so you can get the right answer. So you should know all of this. The first thing, the nursing action, is to begin IV fluids and correct electrolytes. Because when the patient is vomiting, persistent vomiting, can't keep anything down, they risk hypovolumic shock because they are losing fluids, they are dehydrated. So our priority is to restore fluid volume, to prevent hypovolumic shock, to restore perfusion. Okay, so that's our right answer, to begin IV fluids and correct the electrolytes. You see, even in the question, it shows signs of dehydration, dry mucous membrane. That's one of signs of dehydration. And IV fluids that can be given, like normal saline or lactate ringers, can be given as the IV fluids to restore those electrolytes. So in this patient, fluid resuscitation will come before medications or dietary changes. Okay, so let's go through the wrong choices. A says start ondansetron PO and discharge with outpatient follow-up. Listen, the patient is presented with persistent vomiting. Ondansetron, you want to give them that medication, they can't keep anything down. They will throw it out. They will vomit it out. Okay, so they can't keep anything down. So that is totally wrong. Even though ondansetron is antiemetic, if you've seen my GI medications video, it is antiemetics, right? It is part of the treatment. But because they cannot keep anything down, it says persistent vomiting is why we are not giving them. And the other part, because when you are picking your answer, make sure the whole statement is correct, right? Even though when you see start ondansetron, yeah, that's antiemetic, that can help them to suppress the vomiting, but they can't keep anything down. So before the antiemetic gets chance to start working, they've thrown it out, they vomit it. So that's why. And the other part says discharge with outpatient follow-up. You want to discharge a patient with severe dehydration and they have ketones in their urine. That is unsafe. The patient needs IV therapy, hospitalization, fetal monitoring, and not outpatient care. It is totally unsafe. Okay, and the next one is offers more frequent meals and ginger tea only. Guys, run away when you're picking your choices. Run away from any choice that says only, always. They are trick bags. Always wrong. Because truly, look, offers more frequent meals will be one of the patient teaching with hyperemesis gravidarum that, okay, eat frequent meals when you can tolerate it. Eat dry crackers and bland food when you can tolerate it. But it says only and ginger tea. Also, you can tell them to take carbonated drink like ginger ale. Okay, that can help the nausea and vomiting. But these ones can only even help in mild or moderate morning sickness, not for hyperemesis gravidarum. Okay, so it's not our priorities, it's not our immediate action, because diet strategies do not correct the dehydration they are presented with and the ketones in the urine. So the patient needs urgent IV therapy and not dietary counseling. Hyperemesis gravidarum is a serious and severe condition. And since our right answer is C, this is start insulin sliding scale. Why are we starting insulin? Because think about it. Patients that can't keep anything down the stomach will be at risk of what? Hypoglycemia. So they're already at risk of hypoglycemia. Why are we giving them insulin to lower? Hypoglycemia kills more than hyperglycemia. And if you are thinking you want to give them insulin because of the ketones. Now, the ketones in this patient develop in hyperemesis gravidarum is not because of hyperglycemia. It is because of starvation, because their body is breaking down the fat. And that's why ketones occur in this patient. Not because there is hyperglycemia, there's too much sugar in their blood and there's not enough insulin to shift the blood sugar into the cell. That's not the reason why. That will be seen in diabetes. But in hyperemesis gravidarum, the ketones occur because of starvation. So it is not diabetes. We do not have to give them sliding scale insulin. Now let's move on. Our right answer is C. Next one, which of the following finding is most consistent with severe preeclampsia? Now, A, blood pressure of 142/88 and trace proteinuria on urine dip. B, blood pressure of 150/96 with mild pedal edema. C, blood pressure of 162/112, severe headache, visual changes, and platelet that is 90,000. And D, blood pressure of 130/80 with positive fetal movement. Pick your answer, guys. Guys, what the question is asking us is the blood pressure range we will see in severe preeclampsia. Preeclampsia is hypertensive disorder of pregnancy, and we have mild and severe preeclampsia. In severe preeclampsia, as the question is asking us, we will see blood pressure of or greater than 160/100. 160 systolic and diastolic 100. So once you know that, okay, when we're talking about severe preeclampsia, the blood pressure will be between 160/100, will be at 160/100 or greater than 160/100. So you have to pick the number here, and the right number is C for severe preeclampsia. It says blood pressure 162/112, severe headache. And these are other signs and symptoms, key features in severe preeclampsia. Severe headache, visual changes like blood vision. The patient may complain of seeing spots, okay? And thrombocytopenia, that is decreased platelets, and that's why you see a platelet of 90,000, sorry. So that is our right answer. Now let's go to the wrong choices. A says blood pressure of 142/88 and trace proteinuria. This is describing what? Mild preeclampsia. Mild preeclampsia is when the blood pressure is at 140, at or greater than 140/90. And this one is 142/88. So this is describing mild preeclampsia. Okay? And not severe preeclampsia. And in mild preeclampsia, there is also protein in the urine. Now, B says blood pressure of 150/96 and mild pedal edema. This can still fall in the range of mild preeclampsia or hypertensive disorder in pregnancy. And also mild edema is common in pregnancy, right? So this is not describing severe preeclampsia. Severe preeclampsia starts from 160, while mild preeclampsia is from 140 and above. So this can fall under mild preeclampsia and elevated blood pressure in pregnancy. So let's move on. C is our right answer, and this says blood pressure 130/80 with positive fetal movement. Now, normal blood pressure range is when the systolic is less than 120, so let's say between 119, and the diastolic is less than 80. Okay, and this one is 130. So this is showing that the blood pressure is slightly elevated. Okay, this may fall under type 1 hypertension. Type 1 hypertension, the systolic is between 130 to 139, and the diastolic number range is between 80 to 89. So this may fall under type 1 hypertension and not severe preeclampsia. Okay, so our right answer is C. Let's move on. A patient with severe preeclampsia is started on magnesium sulfate, which nursing assessment indicates possible magnesium toxicity and require immediate action. A, respiratory rate of 28 breaths per minute. B, deep tendon reflexes +1+, that is decreased. Now, C, urine output 60 ml per hour, and D, patient report mild thirst. Pick your answer, guys. Guys, the right answer is B. Deep tendon reflexes, decreased deep tendon reflexes, guys. They are simply asking us for signs of magnesium toxicity. And if you've seen my fluid and electrolytes video, I talk about all these electrolytes. Magnesium is part of them. In hypermagnesemia, the signs and symptoms you will see will be decreased neuromuscular function. You will see hypotension, bradycardia, respiratory depression, everything will be low in hypermagnesemia. And the opposite is for the hypo. In hypomagnesemia, everything will be high. So it's opposite way. Okay, so that's why our right answer in hyper. So this question is asking us for magnesium toxicity. In magnesium toxicity, it means the magnesium level is too high to a dangerous level, to a toxic level, and you will see decreased deep tendon reflexes. Okay, and the antidote for magnesium toxicity or hypermagnesemia is calcium gluconate. Okay, so once you notice magnesium toxicity in your patient, the first thing we want to stop the magnesium and give them calcium gluconate as the antidote. Now let's go through the wrong choices. A says respiratory rate of 28 breaths per minute. This is incorrect because I just told you that in hypermagnesemia, magnesium toxicity, too dangerous level of magnesium, toxic level of magnesium, you will see decrease. I said decreased respiratory rate, but this is respiratory rate of 28 breaths per minute. This is a high respiratory rate, so you will not see this in hypermagnesemia. And normal respiratory rate is 12 to 20. So here, it's not, so if you are seeing a respiratory rate of 28 breaths per minute, it's not for hypermagnesemia. Because toxicity, magnesium toxicity, causes low respiratory rate that is less than 12. Normal respiratory rate is 12 to 20, and you will not see high respiratory rate. And C says urine output of 60 mL per hour. This is normal urine output. This is good. This does not show that magnesium is too high or there is at a level of toxicity in the body. So this is wrong. In fact, in magnesium toxicity, you may see decreased urine output, urine that is less than 30 mL per hour, because we know that magnesium is excreted by the kidney. So if you are seeing urine output that is less than 30 mL per hour, then you may consider that as magnesium toxicity. But a urine of 60 mL per hour is in normal range, is good. And this is patient report mild thirst. Thirst has no relationship with magnesium toxicity. This is benign and expected symptoms, so it's not related to magnesium toxicity. So our answer remains B, deep tendon reflexes. Okay, now let's move on. Which statement about placenta previa is correct? A painless bright red vaginal bleeding in the 2nd/3rd trimester is classic of placenta previa. Now, B, a sterile vaginal exam should be performed to locate the placenta. C, placenta previa always resolve before term. And D, fetal distress is the first sign in placenta previa. Pick your answer, guys. Guys, the right answer is A. Painless bright red vaginal bleeding in the 2nd/3rd trimester is classic sign for placenta previa. To remember this, think about the 3 P's. Placenta previa painless. That will help you to remember that, oh, it's placenta previa that you see painless bright red vaginal bleeding. Okay, so this is the right answer. Painless bright red vaginal bleeding, 3 P's with placenta previa. You will also see soft uterus, and it is typical in the 2nd/3rd trimester. Okay, so that's the right answer. Now let's move to the wrong choices. A sterile vaginal exam should be performed to locate the placenta. Never, ever, ever, never you ever, never perform vaginal exam or cervical check when your patient is presented with vaginal bleeding. Never put your hand in that vagina to assess or to examine the cervix when your patient is presented with vaginal bleeding, because that can cause trauma, that can increase the risk of bleeding. And this one saying to locate the placenta, if you put your hand inside to locate the placenta, you can tear the placenta, and that will lead to risk of severe hemorrhaging, trauma. You don't want to. So in any vaginal bleeding, once a patient presents with vaginal bleeding, do not put your hand, do not perform vaginal or cervical check or exam. A transvaginal ultrasound is used to diagnose placenta previa and to locate the placement of the placenta. Placenta previa is when the placenta implants near or over the opening of the cervix. So to confirm where the placenta really is, if it's covering the cervix or it's just near the cervix, a transvaginal ultrasound is what is done. Never inserting the hand. Okay, now C says placenta previa always resolve before term. This is incorrect, because complete or partial placenta previa does not resolve on their own. Placenta previa may require C-section, and corticosteroid may be given to help the lungs of the baby to mature before scheduled C-section. Okay, so that is wrong. And this says fetal distress is the first sign in placenta previa. No, the 3 P's, painless bright red vaginal bleeding is the first sign in placenta previa. Fetal distress may develop later if the bleeding is not controlled, but it is not the first sign. Okay, so that is wrong. So our right answer is A. That's the hallmark. That painless bright red vaginal bleeding is the hallmark of placenta previa. Let's move on. Next question. A woman at 36 weeks with sudden severe abdominal pain, vaginal bleeding, a rigid board-like uterus, and fetal bradycardia most likely has A. placenta previa, B. placenta abruption, C. uterine atony, and D. vasa previa. Pick your answer, guys. Guys, the right answer is B. placenta abruption. Why did we conclude that with the presented signs and symptoms or situation, we have chosen placenta abruption? Because look, placenta abruption is when the placenta prematurely separates from the uterine wall. And the key features in placenta abruption, look at this, sudden severe abdominal pain, because this placenta suddenly and prematurely separated from the uterine wall. Dark red vagina bleeding, rigid board-like uterus, fetal distress like bradycardia. These are the signs and symptoms you see in placenta abruption. So now let's go to what we were presented with. Look, she's 36 weeks and she has sudden severe abdominal pain, which is one of the things I mentioned, vaginal bleeding, rigid bud-like uterus, and fetal bradycardia. Exactly what I said. So this is for placenta abruption. And you will see that rigid bud-like uterus because, think about it, the placenta is attached to the uterine wall. Now the placenta suddenly detached from the uterine wall. Now there's a large hole here. The blood will be accumulating here, and that's how you see the rigid bud-like uterus. The placenta may detach completely or partially. Then the blood will accumulate behind it. That's how you see the that's why you will see that rigid bud-like uterus. So with everything presented to us, we conclude that our right answer is placenta abruption. Okay, so let's go through the wrong choices. A says placenta previa. I've just explained placenta previa, triple P. Placenta previa, painless bright red vaginal bleeding. So that is wrong. And C says uterine atony. Uterine atony happens in postpartum after the baby has been delivered and the uterus fails to contract. You will see those soft, buggy uterus, and it does not cause abdominal pain. You will not see the presentation we are giving. All this rigid bud-like abdomen, severe abdominal pain. You will not see that in uterine atony. It does not cause fetal bradycardia because the baby is already out. So our right answer is not C. And D is vasa previa. Now, what is vasa previa? Vasa previa is when the baby's blood vessel run across or close to the cervix without protection from the umbilical cord or the placenta. So when the membranes now rupture or something called when the water breaks, this blood vessel can tear, causing rapid fetal blood loss and severe fetal bradycardia. So you will see vaginal bleeding in vasa previa, but the blood is not maternal blood. The blood is not the mom's blood. It is the baby, it's the fetus that is bleeding because the blood vessel is torn. That's why the blood will be coming from the baby and not the mother. We see painless vaginal bleeding. The bleeding, the blood is coming from the baby's blood vessel. And in this situation, an emergency C-section has to be done. So the presentation, the signs and symptoms presented to us about our patients is not the same thing you will see in vasa previa. That is why it's wrong. So our right answer remains B. Now let's move on. A woman in active labor has a sudden drop in fetal heart rate to 60 to 70 BPM with deep variable deceleration after spontaneous rupture of membranes. Now, you perform a sterile vaginal exam and palpate the umbilical cord at the intritus. What is the priority nursing action? A. Push the cord back into the uterus and continue monitoring. B. Manually elevate the presenting fetal part and place mother in knee to chest or Trendelenburg position. Prepare for immediate C-section. C. Apply fundal massage and start oxytocin. And D. Encourage maternal pushing to speed delivery. Pick your answer, guys. Guys, the right answer is B. Manually elevate the presenting fetal part and place mother in knee to chest or Trendelenburg position. Prepare for immediate C-section. What do we have here? We have a case of cord prolapse. Umbilical cord prolapse. And what is umbilical cord prolapse? This is when the umbilical cord protrudes or slips through the cervix while the baby is still fully inside the uterus. So the baby is still fully inside the uterus, but the cord, we know that the umbilical cord is what supplies oxygen and nutrient to the baby. That cord has now slipped out, it's now out of the cervix. They should both be in, the baby and the umbilical cord should be in. That is cord prolapse. And how do we know? How do we detect cord prolapse? The cord may be visible or palpable inside the vagina, or during a cervical check, if the OBGYN insert the hand to just examine the cervix, maybe how dilated or just examine the cervix, and he or she sees that, oh, the cord is outside, it shouldn't be there, there's something else here, it shouldn't be there. That's how we can detect cord prolapse. Okay, and the immediate action is to first call for help because it's an emergency. The next thing you have to do as the nurse is to insert a sterile glove, is to put on a sterile gloves. Remember I said sterile gloves, not clean gloves, sterile gloves. And what you want to do after putting on that sterile gloves is to insert your hand in search for the baby's presenting part that may be compressing the cord. Why? Our priority in cord prolapse is fetal oxygenation. We want to prevent fetal hypoxia, that is lack of oxygen supply to the baby. So our priority is for that fetus to get oxygen. So you are looking for that presenting baby part, body part of the baby, of the fetus, that may be compressing the cord. Because when the cord is compressed, there is decreased oxygen supply to the baby. There is cut of oxygen supply to the baby when the cord is compressed. So we are looking for that baby's body part to lift it up off the cord so that oxygen can still get to the baby. Okay? And after lifting it up, listen to this, you have to continue lifting it up until that baby is delivered. In an emergency C-section have to be done. But you have to continue to lift that baby's body part that may be resting on the cord. So that while we are rushing the woman to the OR, the operating room, the cord is not compressed, and some oxygen can still be getting to the baby, and the mother can be put in knee to chest position or Trendelenburg position in anticipation that would help to shift the baby backward and lift the baby off the cord. But the person holding that presenting part will hold the presenting part until the baby is delivered, because we don't want cut off of oxygen from the baby. We don't want fetal hypoxia. Okay, so that's our nursing action. Let's go through the wrong choices. A says push the cord back into the uterus and continue monitoring. Never push the cord back. If you push the cord back, you will compress the cord more, and that will lead to fetal hypoxia. The fetus, the baby, will not get enough oxygen because the cord is compressed and squeezed in. Never do that. One thing I forgot to mention is, if the cord is dangling outside the vagina, what you want to do is you want to put a warm, sterile saline soaked towel. You want to soak a towel, a clean towel in warm saline, and use it to cover the umbilical cord if it's dangling outside the vagina, very visible outside the vagina. Okay, so you never push back the cord. And it says continue monitoring. Monitoring alone is not enough. This is a time critical emergency. A C-section has to be performed immediately. So that is wrong. And C say apply fundal massage and start oxytocin. Fundal massage and oxytocin is very useful in postpartum when the uterus fails to contract, not in cord prolapse. You know that if you should give oxytocin in cord prolapse, oxytocin increases and causes strong contraction. These strong contractions will compress the cord even more and squeeze that, and that will cut off oxygen supply to the baby. We do not want that. Okay, so that is wrong. And D is encourage maternal pushing to speed delivery. Pushing will increase pressure on the cord and worsen hypoxia. We don't want the mom to push, because if you push, that will put more pressure on the cord. That's why it's an immediate C-section have to be done. Most cord prolapse requires immediate C-section. Okay, so that's why our right answer is B. Okay, now let's move on. Which of the following increases the risk of uterine rupture during labor? Select the best single answer. A parallel transverse horizontal cesarean scar only. B, use of oxytocin to augment labor without close monitoring. C, that's B. C, maternal age under 25 years. And D, cervical sacrilege placed in the first trimester. Pick your answer, guys. The right answer is B, use of oxytocin to augment labor without close monitoring. Let me explain it to you. What the question is asking us, that risk of uterine rupture. We know that uterine rupture is the rupture of the uterine when there is a tear in the wall of the uterine, usually during labor, right? And one of the risk factors for that uterine rupture is use of oxytocin. Let me explain it. You know that when you use oxytocin to augment labor, to cause contraction, oxytocin causes strong contractions, and it also increases contractions, right? So if this oxytocin is used inappropriately or without close monitoring, the contractions can become too strong and too frequent, and this will put excessive pressure on the uterus. It will also increase pressure or stress on the previous uterine scar. Previous uterine scar is like when a woman has had C-section before. The C-section, there'll be an incision, will leave a scar on the uterus. Especially if the previous incision was a vertical or classical incision, which is weaker. So during those strong contractions, the scar can tear open. That will cause uterine rupture. Okay? So that is why our right answer is B, when you are using oxytocin without monitoring. And the oxytocin bringing those too frequent, too strong contractions without giving the uterus some time to rest or break. The contractions are just very frequent and too strong. That can cause uterine rupture. Other things that can cause uterine rupture is trauma. Any injury to the abdomen. If the woman fall on her stomach, if there is a car accident, if she's involved in a car accident and she hit the stomach, if there is a hit or stab in the stomach, that can cause the uterine to rupture. That's why our right answer is B. Let's move on to the wrong choices. A says prior low transverse horizontal cesarean scar only. Run away from only. But let's talk about this transverse cesarean scar. A low transverse scar has the lowest risk of rupture. If the incision that leads to scar was, I've told you before, vertical or classical incision, this is weaker scar, and it carries the highest risk of rupture, of tearing. So prior low transverse cesarean scar has the lowest risk of rupture, but classical vertical incision carries the highest risk of tearing, leading to uterine rupture. Okay, so that is wrong. And it says maternal age under 25. Age is not a factor in uterine rupture, and young maternal age does not increase risk of uterine rupture. So this is wrong. And this is cervical sacrilege placed in the first trimester. A sacrilege is a stitch around the cervix to prevent preterm birth, to prevent the baby coming too early than the expected delivery date. Why? Because some women have short cervix, so it is easy for the baby to slip out of the cervix prematurely. So they will create a stitch around the cervix to close it up from the baby slipping down or being born before time, preterm, to prevent preterm birth. Okay, so that's what it's used for. It has no connection with uterine rupture risk. It has no connection with uterine rupture risk. So that is wrong. Let's move on. A neonate delivered after shoulder dystocia is most at risk of which injury? A says fracture femur, B says brachial plexus injury, herb palsy, and C radius deformity, D transient neonatal hypoglycemia. Pick your answer, guys. Guys, the right answer is B, brachial plexus injury, herb palsy. Shoulder dystocia is when the head of the baby delivers, but the shoulder gets stuck behind the mother's pubic bone. And one of the signs of shoulder dystocia is turtle sign. Turtle sign is like a turtle, when the turtle bring the head and put it back. So turtle sign is when the baby head come out and then retract back because the shoulder is stuck. Okay, so that's shoulder dystocia. And one of the nursing actions for shoulder dystocia is macrobot maneuver. That's like putting the mom into chest to help widen the pelvis so that the shoulder of the baby can slip down the pubic bone and be able to come out. Or suprapubic pressure. The nurse may apply firm pressure right on the pubic bone in anticipation to push down the shoulder so that the shoulder can come out, right? To push down the dislodged shoulder, the stock shoulder, to dislodge the stock shoulder. So all the traction used during delivery of this baby can stretch or damage the brachial plexus nerves, and this will lead to herb palsy. And in herb palsy, you will see weak or absent movement in the affected arm, and you may also see waiter steep position. This is when the arm is abducted, internally rotated, and the wrist flexed. So look for the picture so you understand how waiter steep position looks like. Okay, all right, guys, this is the most common injury after shoulder dystocia, so that's our right answer. Let's go through the wrong choices. A says fractured femur. Shoulder dystocia affect the upper body, not the legs. You will see femur in the thighs. Okay, femur fractures are rare during birth. All right, so that is wrong. C says radius deformity. The force applied during shoulder dystocia is to the upper body, to the shoulder, and not the wrist or forearm. This is when you're looking for radius pulse here. So forearm bones like radius injury, not typical in shoulder dystocia. That's wrong. And this is transient neonatal hypoglycemia. This is primarily associated with neonates or babies that with diabetic mothers, not shoulder dystocia. This has nothing to do with shoulder dystocia. We see neonatal hypoglycemia in neonates, in babies that the mom has gestational diabetes, because they be getting those sugar from the mom and now they are delivered. There is no direct source for that sugar they've been getting in the uterus. Now their blood sugar will crash, hypoglycemia. So this has nothing to do with shoulder dystocia. Okay, let's move on. Which diagnostic approach is recommended for suspected placenta previa? A. Immediate sterile vaginal exam to locate the placenta. B. Transvaginal ultrasound to confirm placenta location. C. Rely on clinical bleeding pattern alone. And D. Amniotomy to speed labor and locate placenta. Pick your answer, guys. Guys, the right answer is clear. I've even mentioned it earlier. Is transvaginal ultrasound to confirm placenta location. Transvaginal ultrasound is the safest and the most accurate way to determine if the placenta is fully covering the opening of the cervix, or it's just near, or it's just implanted near the cervix. And it is also safe because the probe that will be inserted in the vagina will not touch the cervix. Remember, I said never perform vaginal exam in your patient that is bleeding. Never put your hand, is what I mean. Never put your hand in that vagina. A probe can be used because this probe will not touch the cervix. So there is no risk of this probe tearing the placenta up and causing severe hemorrhage. So never manually put your hand in the vagina to examine the cervix or vagina when your patient is presented with vaginal bleeding. So the best way to know about placenta previa, to know the placement of the placenta, is inserting that probe. And that probe will give an image on the screen and we'll be able to see where the placenta is located. So that's the right answer. Never perform vaginal exam during an active vaginal bleeding in your patients. Do not put your hand to manually check. Saying this is contraindicated. C says rely on clinical bleeding pattern alone. Yes, we know that painless bright red vaginal bleeding is the hallmark of placenta previa, but that will not tell us the placenta placement, because we need to know if the placenta is fully covering the cervix or if it's just right beside the cervix. That will determine if we'll have to do emergency C-section immediately. D. Amniotomy to speed labor and locate placenta. Now, amniotomy is where the water breaks, like rupture membrane and the water breaks, right? If the prescriber or the OBGYN should try to rupture the membrane manually, this is dangerous in placenta previa because it increases the risk of severe hemorrhage, fetal distress, especially if you do not know or you are not sure of the placement of the placenta. While you go in to manually rupture the membrane, you may puncture that placenta. You may tear the placenta. So this is wrong, okay? The right diagnostic approach is to use transvaginal ultrasound to confirm placenta location. Next question says, a 28 weeks gestational patient with gestational diabetes controlled by diet asks why she needs a 1 hour glucose screen at 26 weeks. The best nursing explanation is A. This test looks for long-term diabetes, HbA1c. B. This screen identifies elevated blood sugar that can make the baby grow too large and cause delivery problems. C. This test check for protein in the urine. And D. This test measure magnesium level. Pick your answer, guys. Guys, the right answer is there. It's very simple. The right answer is this screen identifies elevated blood sugar that can make the baby grow too large and cause delivery problems. Let's talk about gestational diabetes, okay? This is when a woman develops diabetes during pregnancy, especially a woman that was never diabetic prior to pregnancy, but in pregnancy she become diabetic. And in gestational diabetes, the patient will develop glucose intolerance. Okay, And the signs and symptoms for gestational diabetes is often asymptomatic, and that is why the glucose tolerance test is ordered between 24 to 28 weeks gestation to detect gestational diabetes. Because if we do not detect this and control it, this will lead to macrosomia baby, large baby, because the woman is glucose intolerant. So she's having severe hyperglycemia, a lot of sugar in her blood. The baby will be taking in all of this sugar and the baby will be growing big. Okay? So macrosomia baby or fetus is also like a sign and symptom to detect gestational diabetes, because if you see that the fetus is bigger than the gestational age, you want to wonder why, and that may trigger you or cause you to tell them to go for the glucose test screening to detect if they have gestational diabetes, because it's often asymptomatic. And also another signs and symptoms you may see will be typical of diabetes mellitus signs and symptoms, like polyuria, polyphagia, polydipsia, excessive urination. And pregnancy naturally causes excessive urination, so you may not know they have diabetes, you may just think they're having excessive urination because of the pregnancy. So that's why that screening is very important to screen for gestational diabetes. And the treatment, lifestyle modification, like diet modification and lifestyle modification, like decreasing carb in the diet and doing tolerable exercise. And if this does not help, then insulin therapy will be ordered for them. Okay, so you have idea of gestational diabetes. So the reason why they do the 1 hour glucose screening at between 24 to 28 weeks, but for this patient it was ordered at 26 weeks, is to detect gestational diabetes, to prevent large baby that may cause difficult delivery, that may cause delivery problem. Because if the baby is too big, one of the complications of gestational diabetes is, like I said, macrosomia baby, shoulder dystocia, because the baby is now too big. Their shoulder may stuck behind the mother's pubic bone. C-section, because the baby is big, C-section may be done. Okay, so these are the reasons why we screen for gestational diabetes, especially because it is asymptomatic. All right, let's go through the wrong choices. A says this test looks for long-term diabetes HbA1c. This is incorrect, because the 1 hour glucose test is not to detect, it's not for HbA1c. So this is not true. HbA1c is a separate test used to measure average blood sugar over 3 months. So this is wrong. Okay, so the 1 hour glucose test is not for HbA1c, it is to detect gestational diabetes. Now, C says this test checks for protein in the urine. Now, checking for protein in the urine is to detect preeclampsia and not gestational diabetes. So this is wrong. Okay, now, and this test measures magnesium levels. Magnesium levels are measured during magnesium sulfate therapy. They are monitored for magnesium toxicity and not in gestational diabetes. Okay, so this is wrong. Okay, and our last question, guys, I'm glad we made it. Last question. A woman arrives after a high-speed motor vehicle collision at 34 weeks pregnant. She is hypotensive and tachycardic. The fetal heart rate shows recurrent late decelerations. Which complication is most concerning and must be considered immediately? A is placenta previa, B is placenta abruption, C is umbilical cord prolapse, and D is gestational trophoblastic disease. Please pick your answer, guys. That's the right answer is B, placenta abruption. Placenta abruption is when the placenta prematurely separates from the uterine wall. And if you've been listening to me, one of the risk factors that I've mentioned to you for placenta abruption is trauma. Trauma, like any injury to the abdomen, like a car accident where the woman hit the stomach. If a woman falls on her stomach, if there's a direct hit or stab on the stomach, can cause the placenta to separate from the uterine wall. All these risk factors are the reason why we are picking placenta abruption. And in placenta abruption, you see late deceleration. Okay, so that's why we are picking placenta abruption. And also, as you can see, it shows that The woman, she's hypotensive and tachycardic. Signs of hypovolumic shock. It means she may be bleeding internally, losing blood, and that can lead to hypovolumic shock. So this clinical picture presented to us is classic emergency placenta abruption scenario. Let's go through the wrong choices. In placenta previa, you see bright red vaginal bleeding, not trauma-related late deceleration as is seen for the fetus here. Placenta previa is not caused by accident or any hit to the stomach, and it would not suddenly appear after a crash. It appears within between second and third trimester, so that's why it's not placenta previa. Now, C says umbilical cord prolapse. Umbilical cord prolapse causes deep variable deceleration and not late deceleration, so it's wrong. And this is gestational trophoblastic disease. This is a complication of early pregnancy with abnormal trophoblast growth. It has no relationship with trauma or 34 weeks pregnancy, and it will not cause late deceleration after a motor vehicle accident. Okay, so our right answer that really matches the presentation, the clinical scenario given to us, is placenta abruption. All right, till next time, guys, take care.